Good morning, guys. We'll probably wait until 5 past. Just let your colleagues know that we're about to start the meeting. Today, Dr. Ganyani will present an interesting case on early onset fetal growth restriction. Hopefully, we may be joined by the pathologists so that they can probably give us more flesh or a comment on placenta histology. But we want to welcome you to the meeting. Please let your colleagues know that the meeting is starting. We will just wait until 5 past, then Dr. Ganyani will go on. Like I have always said, please listen carefully to what he's going to say. Ask him questions, because if you don't ask him questions, you are not improving his learning. So make sure you ask him some questions at the end, and you also probably pass comments or on the presentation or on the case. But otherwise, let's just wait until 5 past. You can get yourself ready to share the screen, Dr. Ganyani. Dr. Ganyani is a registrar in obstetrics and gynecology. He's rotating through the fetal medicine unit for his 6 weeks. I think he will be finishing next week, if I'm not mistaken. So yeah, so listen to him carefully as he presents today. Thank you. So get yourself ready, Dr. Ganyani, to share the screen. Then as soon as you are aware 5 past, you can start. Dr. Ganyani, are you there? Do you want to share your screen, please, so that we know you are ready to get going? He's saying double click to enter full screen mode because we can't. Yeah, there we are. Yeah, if you can be on slideshow, make yourself ready. I think as soon as you are ready, please start the presentation. Please unmute yourself and start speaking.
Good morning, Good morning, everyone. And unfortunately, we have tested the slides, they're not moving. I think we need to stop sharing and reshare again. Oh, now they are moving. I'm sure you can see the slide on demographics.
Yes, you can go on slideshow. We can see you, but kindly go on slideshow.
Okay. Just a second.
Just go on slideshow. We can see you quite well. We can see the slide, and you're loud and clear. Yeah, I think we are good to go. Please go ahead.
Thank you, Dr. Irenga. Good morning, everyone. Once again, my name is Dr Ganyani. I'm going to be presenting on a patient who has early onset intrauterine growth restriction. My patient is Mrs. NS. She's 33 years of age. She's in a third pregnancy with one child alive and a history of having suffered a miscarriage in the past. Her last normal menstrual period was on the 21st of May 2024, and the expected date of delivery, according to dates, was the 28th of February 2025. When we saw her, the estimated gestational age was 33 weeks and 5 days. Initially, this is a patient who was referred from a local scanning center for a small for gestational age and absent end diastolic flow Dopplers in the umbilical arteries after they'd done 2 ultrasound scans that were 3 weeks apart. In the current pregnancy, this is a pregnancy that was not planned, but it is wanted. So the patient married, she wedded on the 11th of May in 2024, and she had to resume work the following month on the 19th of June in the United States of America. She works for a cruise ship company, which is based in the United States of America, and she spends most of her time on sea. So she went back to work after about a month of marriage, and then she missed a period sometime on sea, over the sea, and they were close to Greece, but she had no symptoms of pregnancy. She did not do anything about it as she was on sea, and then when they made landfall on the 15th of August in 2024 in Turkey, she managed to see a health practitioner. Her blood pressure at that time was 120 on 80 millimeters of mercury. The pulse was 84. Blood tests that were done, including a urine pregnancy test that was positive. They found blood group. She has blood group B positive. Hepatitis B and C were negative. HB was 12.7. She was free of syphilis, and the liver function tests were normal. Ultrasound scan was not detailed as we have seen in the fetal medicine unit. They only mentioned that she was 12 weeks of gestation with a crown rump length of 52 millimeters, and everything was bundled up and said to be normal. As was required contractually, she had to disclose to the employer that she was now pregnant, and they gave a choice to either continue with the pregnancy on sea or to go home. The situations were such that she decided to go home. She made the decision on the 15th of August, and by the 18th, that's how serious they are. In 3 days, she was already back in Zimbabwe. She immediately went to a nearest medical center, a private medical center, and booked for a ANC antenatal care, and that was at 13 weeks and 6 days of pregnancy. After booking, the patient went for 4 more antenatal contacts, and what they noted there was that her height of fundus was not growing. It was noted to be 14 centimeters height of fundus at 22 weeks and 4 days of gestation. An ultrasound scan was done at 21 weeks, and it was repeated at 24 weeks. They decided to redate the pregnancy at that point in time, And when they noted that the patient had intrauterine growth restriction, they referred the patient to Salim Gabe Hospital. And on the 13th of November, she had a first FMU ultrasound scan, which was again repeated on the 15th by a more senior member of staff. At that point, it was noted that she had small for gestational age, femur length and humerus length, and they were both less than 1%. The BPD, bilateral diameter, and head circumference were both appropriate for gestational age. The abdominal circumference was noted to be small for gestational age at 1.1%. Umbilical artery Dopplers were confirmed to have absent end-diastolic flow, which was already noted by the previous scanners, and it had high PI. The rest of the Dopplers were normal. Amniotic fluid, a single depressed pool was also normal. The estimated fetal weight at that point was noted to be 411 grams, plus or minus 61 grams, which was less than 1%. There were no obvious structural defects that were noted, or there were no markers of chromosomal abnormalities, and the placenta was noted to have multiple diffuse infarcts. Counseling was done. The patient was to have 2 weekly placental disorder and fetal defects clinic assessment in 4 weeks. She was prescribed to take aspirin 150 milligrams once a day and Clexane 40 milligrams once a day. Luckily, and I say luckily because most of our patients at Salim Gabe Hospital may not be able to afford Clexane, and luckily this patient was able to afford the injection, and she took it. Placenta was to be sent for histology after she had delivered. On the 27th of November, you will now see that this patient was now coming in for the serial ultrasound scan assessment that had been prescribed. From the 27th of November, an ultrasound scan was done, which showed that the biparietal diameter, head circumference, abdominal circumference, and femur length were all less than 1%. Estimated fetal weight at that point was 550 grams, which was also less than 1%, and the umbilical artery Dopplers showed reduced end-diastolic flow with an increased PI. On the 2nd of December last year, the scan was pretty much the same. 10 days later, on the 12th of December, she had to go counseling on whether she would have a termination of the pregnancy against expectant management. The patient chose to continue the pregnancy, and at that point, she decided then to officially book at Salim Gabe because she was just being seen at the FMU unit for ultrasound scan assessments. So she then booked a pregnancy, and the ultrasound scans continued to be the same. But you will notice that the single depressed pool of amniotic fluid was 50 millimeters on the 18th, which drastically dropped from 50 millimeters to 18 millimeters from the 18th of December to the 9th of January without draining. The patient did not drain, but the single depressed pool just shrunk like that. And when she was scanned again on the 13th of January, the oligohydramnios had even declined to 12 millimeters. And at this point, she was admitted for dexamethasone course, which she received. And another scan was done on the 15th. And at this point, delivery was advised. She could not go in for the ultrasound, the cesarean delivery that had been prescribed on that day, but she managed to go for cesarean section on the following day. So this was on the 16th of January, 2025. I apologize for the error there. The bottom of the slide is 2025, not 2024 as is written there. And at that point, the gestational age at delivery was 33 weeks and 6 days. Let's talk about previous pregnancies. She had her first pregnancy in 2015 at Berry General Hospital. She had to undergo induction of labor for prom, and she delivered a baby boy who is alive and well. The delivery weight was 3,500 grams. This was in a first pregnancy. And in this second pregnancy that she now has, she suffered she suffered a miscarriage before the second marriage. She suffered a miscarriage in 2022 of April, and she had to be managed medically with a cytotec, misoprostol. Menak was at 13 years of age. She was growing appropriately with age, for age. She had 3 days of bleeding in a 28-day cycle, which were regular. Koitek was at 23 years of age. She has had 5 partners in life. 2 were not protected because they were her husbands. The first husband and the second husband. I'll talk more about it a little bit later. She has not had cervical cancer screening at the moment, but contractually, it is mandatory that she has STI screening at work, and she does that annually, and they've been negative up to now. Past medical and surgical history, it's only significant of the fact that she has chronic allergic sinusitis, for which she takes a nasal spray. She is quite a versatile lady. She has 7 O-levels passes, 2 A-level passes. She has trained in pharmacy assistants, emergency medical dispatcher, and she has had on-job training in hospitality now that she's working in on a cruise ship. Her husband, the first husband, left her for greener pastures, and he never came back. That was in 2015. So she then had a miscarriage in 2022 with another partner, and remarried in she then remarried in 2024 to a co-worker. She works as a cruise ship suit host. The company is based in the United States of America, but she spends most of her time all over Europe and America over the sea. She spends a maximum of 2 months in Zimbabwe. The rest of the time she's away. And her husband is a co-worker. Her income is estimated to be about 4,000 euros annual per month. And unfortunately for a maternity leave is not paid for. This is a picture of the family tree. The parents, the mother is, her mother is hypertension. The rest of the siblings, the second born suffers from asthma. There are no other chronic illnesses, no congenital malformations in the family. This is the ultrasound scan that became the last straw that was done on the 15th of January that led to the delivery. So you can see that there is a reversed end-diastolic flow in the umbilical artery, and the middle cerebral artery has increased the end-diastolic flow, which is commensurate with a redistribution picture. All parameters, as you can see, they are less than 1%, including the estimated fetal weight. So, like I said, the patient had to undergo cesarean section on the 16th of January. That is just a picture of some of the Dopplers that were recorded. She had to undergo a cesarean section on the 16th. So in summary, I have presented a 33-year-old who is in a third pregnancy with only 1 child alive from a first marriage and none in the current marriage, with the previous first trimester miscarriage, whose pregnancy has been noted to be not growing on assessment without identifiable risk factors, and she has opted for expectant management. On examination, she was alert, LOC 15/15 stable. There was no jaundice. She was not pale, not cyanosed. She did not have edema. The fetal heart was noted. It was regular. She was normotensive, and vaginal examination was not indicated. She was not edematous. So progress, she had a cesarean section done on the 16th of January and delivered a child, a boy, at 33 weeks of gestation and 6 days. It's a boy and the weight was 850 grams. There's a picture of the child in an incubator in NICU, Harare Central Hospital, Salim Mugabe Hospital. The APGARs were noted to be 6 on 10 and 7 on 10 at 5 minutes. The baby was admitted in NICU, and unfortunately, the baby succumbed on the 18th of January 2025, that is on day 2 of life. And the cause of death was complications of prematurity, and the patient was discharged home the following day. We managed to submit the placenta, albeit with some challenges, but we submitted the placenta to histology. And this is the detailed report from the pathologists. The pathologists, they apologized for minor clerical errors. Some spellings are wrong, but this is not the final report. I had to coerce them to give me a report because of this presentation. However, the placenta was noted to have massive perivillous fibrin deposits. This is the hallmark of the report. I will entertain some questions on the history of the patient before we move on to the discussion. Over to you, Dr. Ganyani. Dr. Ganyani, I think you could be muted.
Doc, I think we lost you. I don't know whether it's me who lost you on your last statement. Are you still there? Was that we didn't hear anything?
Okay,
Still...
I'm here, Doc. Which part of which slide was the last one? Which slide did you last see?
I mean, the last slide of the histology report. What did you? Maybe you can just repeat the whole slide, the histology.
Okay, thank you. I'll take that again. This is the histology of the placenta that was submitted to histopathology, and the hallmark of the report is that there were massive perivillous fibrin deposits that were noted in the placenta. Unfortunately, this is not the final report, so you will find clerical errors on it. The pathologists apologized for that.
So is the pathologist with us in the meeting? Anyone?
Good morning, Doc. I'm in the meeting. It's Dr. Sunwa, Senior Reg from Pathology.
Great. Thank you so much, Dr. Sunwa, for making time to attend this meeting. Maybe would you want to explain the report a little bit, Dr. Sunwa, in terms of the maternal and the fetal side of this placenta, to say what was wrong, if there was anything wrong, from both the maternal side and the fetal side of the placenta?
Oh, okay. So from the maternal side, the villi were in keeping with third trimester villi, and there was minimal syncytial knotting, and then we didn't have any decidual arteriopathy. There was no signs of infection, no histiocytes, no lymphocytes or plasma cells. And then, but what was quite marked when we were looking at the slides was the fibrin deposition around the chorionic villi. It was quite marked. but everything else, even on the grossing, there were, I think, about 3 coils for every 10 centimeters, which is within normal limits. There was no evidence of funicitis. The membranes were clear. There was no evidence of chorioamnionitis, but just that fibrin deposition, which was quite marked on the slides. I think next time when you have another presentation, I'll just take photos so that I can also demonstrate these features.
Thank you so much, Dr. Sona. I think that is very helpful. I think to the next presenters, please take note that we have a lot of placenta insufficiency cases, and I think we should send more samples to Dr. Sona so that Dr. Sona becomes our placenta expert, so that we can understand more what's going on. Any comments on the case so far from the audience? Anything you want to comment? Doc, how were the uterines? Did you report the uterine arteries in this case? Because I thought I missed the uterine arteries. I understand that the umbilical Doppler was bad, and but the uterine arteries, do you report on them?
Yes, Doc. On this final report here.
On the initial assessment, obviously they were done probably on the initial assessment. Were they
Yes.
uterine?
On the initial assessment, there was notching on both the right and the left uterine arteries. On the last straw that is currently projected, they were not documented. I think because the decision had already been made.
Yeah, but when you are making this kind of presentation just for future setters, we really want you to outline the issues of Dopplers, including the images, the initial assessment, so that we know where we are starting from. In terms of the Dopplers, even the graphs, you should show the charts to convince everyone that this is abnormal. That is what we expect. Then Dr. Madebo is raising the hand. Do you want to go ahead, Dr. Madebo?
Okay, thank you very much for the beautiful presentation. Yes, I hear from the pathologist that there were no signs of infection on the placenta. Not sure if all torches cause placental pathologies, but I wanted to ask, did you do a torch screen? Over.
No, that's the question. Was a torch screen done here? Because it's a standard test we do on all patients who are small babies.
Okay, thank you so much for the question. Unfortunately, a touch screen was not part of the panel. The majority of the tests that were done were the ones that were done in Turkey. Hepatitis B, C, those were the ones that were done. HIV, that panel.
Are you sure about that, Doc, or you missed it? Because we routinely order torch on all women with small babies. Or we could have missed it in the notes.
I could have missed it. There's that chance, but I didn't see it on all the documents that I had.
Okay. But that's a very important question. Please take note of this, that all small babies you order torch, and the results have to be looked for or to be followed up whenever it is done. It's a very important question, that one. Dr. Dakro, please go ahead.
Morning, Dr. Virenga. Morning, everyone. Okay,
Morning,
I wanted to confirm with Dr. Ganyani. Maybe I missed it when he presented earlier on. Was this patient screened for aneuploidies when she had the first trimester scan? And on delivery, upon delivery, did you assess for any syndromic features on the baby? And another question for the pathologist, since on ultrasound scan we were seeing multiple infarcts, I wanted to confirm if they checked for the infarcts on histology, and he said that there was just fibrin deposit. In this patient, we were following her up for early onset fetal growth restriction, which is mainly a problem that affects even the blood vessels. But I thought I heard him say there was no arteriopathy. So the picture is a bit confusing. It's not, the histology picture is a bit confusing for me. I don't know, maybe if you can explain it a little bit more.
Please go ahead, Dr. Sun. Maybe we start with Dr. Suna, then we come back to you, Dr. Ganyani, to answer Dr. Ndagura's question.
Thank you, Dr. Ndagurwa, for the questions. The first ultrasound scan that was done in Turkey was not detailed. It only documented the crown rump length. However, the scan that was done, the first ultrasound scan at FMU was quite detailed, and there were no stigmata for aneuploidy that were noted. I think that was the question that you posed to me. Do you have another? Did I miss another question towards me?
Doctor, I think what Dr. Ndagura is highlighting is whenever you present a fetal medicine case, the aneuploid screening should always be mentioned. You say, well, this woman offered aneuploid screening, yes or no? If she was offered, did she take it or she declined? This is missing from your presentation. Because in figure medicine, aneuploid screening is a must that every woman should be offered. So this person could only answer if you had asked the patient the right question. To say, when you were in tech, were you screened for Down syndrome? She could have been screened, but as long as you don't ask, you never know. Or she was offered and she declined. So, yeah, so it's something to pay attention to. That when you are doing a fetal medicine presentation, you can't jump mentioning the issue of aneuploidy in your presentation.
Thank you so much for the education, Dr. Ganyani.
Dr. Suna, do you want to come in with the second question? Because what Dr. Ndagura is saying is completely what everyone is thinking. Say we have damaged uterine arteries on the mother's side. We have damaged umbilical arteries, but histology is saying something else which is not in line with what we saw clinically.
Yeah, it's unfortunate that I didn't have the photos, but on the vessels, even in the umbilicus gross, we didn't have anything to note any pathology, but even on the histology, both the normal architecture was preserved with no evidence of phenicitis, and on the chorionic villi, the capillaries were less than 10, so it didn't even point out to chorangiosis. There was no atherosclerosis. So on the vessels, they were all patterned with no evidence of decidual arteriopathy.
Okay. So Dr. Suna, in cases of maternal vascular malperfusion or fetal vascular malperfusions, what is it we expect to see? Because we see a lot of these cases with very high uterine arteries or very badly deranged umbilical artery Dopplers. Or what kind of histological pattern is consistent with, or do you think we should see if we have vascular malperfusions on the other side?
So with maternal vascular malperfusion, you'll get accelerated villus maturation, increase in syncytial nodes, and sometimes you can have distal villus hypoplasia. And then with fetal vascular malperfusion, it's mainly the vessels in the chorionic villi that are affected. Sometimes they're completely occluded and they're not maturing in keeping with the gestational age. So with the fetal, usually the villi are immature for that age. And the vessels usually have not matured enough, and some of them are actually completely occluded.
Okay. So, how easy is it to diagnose in our own laboratory to diagnose chronic histiocytic intervillositis? Is it something?
Yeah, it's because the histiocytes, you can pick them out, but now because we rarely get these placentas, so sometimes we might miss them just because we're not seeing a lot of placentas. But in this case, we actually had to show it around just to make sure we didn't miss anything.
Right. I think to the audience, you can hear what Dr. Sima is saying here, that we are starving them of the placentas so that their expert is affected because of that. So let's try to send as many placentas of this poorly growing baby as we can to them, so that they get to look more and more. And I think as they look more and more, they will begin to tell us lots of these pathologies that we always suspect will never get to diagnose. So please take note of this, that all those abnormally small growing babies, like in this case where there's no chronic, where there's no gestational hypertension, let's send all these babies placentas for histology, please. Because we want them to look at more and more of these placentas. That way, they will also, share with us more and more information about what's going on and probably possible therapies that we can deploy for such cases.
At what cost, Doc? And which lab?
So even if you send to Pari, it's actually easier because they're under fives. They won't pay anything.
Excellent. I think, thank you so much, Joe. We have lots of these small babies, unexplained, some who fail to grow as early as 20 weeks. We will get you those placentas so that you can look at them. But thank you so much for that.
Thank you.
Any more comments on the case before Dr. Ganyani takes us through his discussion? But it's a very depressing case that we just witnessed. It's not the only case. Of late, sometimes cases come like outbreaks. Of late, even in the private sector, we're following up about 3 ladies whose babies started failing to grow at 20 weeks, and they are not gaining weight. So without any risk factors for placental insufficiency. So yeah, so these are some of the challenges that we face in our clinical practice, that we have these placental insufficiency cases that you can't explain and that you can't counsel the woman properly. Yes, Dr. Madebo, go ahead.
Okay. Not sure if we have a definitive diagnosis, but probably a question that would come is, how would you counsel the patient for future pregnancies in this case?
The diagnosis is there. The massive perivillous fibrin deposition is a placenta pathology that is probably a recurrence of about 20%. So the woman needs to be counseled that she is more likely to have it in 1 in 5 cases. In terms of therapy, there's very limited option for therapy for this kind of cases. If it was CHI, we probably could try prednisolone and also Clexane and maybe some aspirin as well. But unfortunately for this one, it's a little bit tricky. We can't. There's no evidence that it will work for her. But however, we're still going to give her aspirin and Clexane in the next pregnancy to see how best she can be helped. But the only plausible cause which has been identified by histology is massive perivillous fibrin depositions. That would be the cause for placental insufficiency in this case. Dr. Ganyani, do you have a discussion to do? If you have about 18 minutes to go through it.
Thank you, Dr. Verenga. Thank you, everyone, for the insightful discussion. I do have a discussion, but I'm going to run through some of the slides in the interest of time. My slides are not moving. So basically, we are looking at the placenta. As far as placental insufficiency is concerned, the placenta does not provide sufficient oxygen and nutrients to the fetus. If I'm going to borrow Dr. Verenga's words, the placenta delivers oxygen, nutrients, and water to the baby. And when it fails to do that, that's when we have placental insufficiency. And it is important to emphasize that early detection can improve the outcome of the pregnancy. So there's normal placental development, which consists of the formation of chorionic villi, which facilitate the oxygen and nutrient exchange. And there is remodeling, which is important, which happens in the first and second wave of trophoblastic invasion between 8 and 10 weeks, and also between 16 and 18 weeks of gestation. So other functions are the endocrine functions of the placenta, where it produces hormones. The pathophysiology of insufficiency, there is vascular maladaptation, poor spiral artery remodeling, which leads to hypoxia, inflammation and immune dysfunction, which is basically chronic inflammatory conditions. They affect placental function, like if you have chronic hypertension, gestational hypertension, diabetes mellitus, chronic renal failure. And there are some structural abnormalities as well, where the placenta growth is abnormal and it leads to malfunction. So as we already know, hypertensive disorders in pregnancy, whether it's chronic hypertension or it's gestational hypertension, preeclampsia, eclampsia, these are conditions which are associated with placental insufficiency. Diabetes mellitus or gestational diabetes mellitus, these are conditions that we already know about as causing placental insufficiency. But I wanted to zero in on the diagnosis of this particular individual. So we have autoimmune and immune-mediated disorders, for example, antiphospholipid syndrome, which apparently I think we are not screening enough in our patients, and the systemic lupus erythematosus. But the diagnosis that we found in our particular patient is chronic histiocytic intervillositis. And this is a rare inflammatory condition causing placental villus damage. It leads to fetal growth restriction and recurrent pregnancy losses, as Dr. Verenga has already alluded to. It is a 20% recurrence rate. It is characterized by infiltration of maternal histiocytes in the intervillus space. So I have a picture there to try and help Dr. Sunwa to further illustrate what he was explaining. So you will find that within the intervillus spaces, that's where you have a lot of these macrophages infiltrating. So basically, it's infiltration of maternal macrophages into the intervillus spaces of the placenta. And there is perivillus fibrin deposition, which is associated with fetal growth restriction. There is an increase in stillbirth and miscarriage rates in these patients. The incidence of this condition is about 6 in 10,000. So it's a rare condition, but I think we are not looking enough for looking out enough for this condition. And it usually happens after 12 weeks of gestation. I was looking at the situation where this patient has suffered a pregnancy loss in the past, and now they are having this abnormal outcome for their baby. However, it was below 10 weeks in in the first pregnancy, so I cannot really link it to CHI. There is a 25 to 100% recurrence, but I have been corrected here by Dr. Verenga that it's 25%, it's 20%. I took this from this journal that is.
Sorry, let me correct that. CHI is a recurrence rate for about 50%. But perivenous fibrin deposition on its own is a recurrence rate of 20%. So let me correct that so that people don't get confused. So you are right, your figures, the 25 to 50, 100%, that's it for CHI, chronic idiopathic intervillositis. But for perivenous fibrin deposition in isolation, like in our case where they didn't see histiocytes, the recurrence rate is about 20%.
Thank you, Dr. Verenga, for the in-depth clarification. There is no proven treatment. There's no treatment that has proven efficacy. However, immunosuppression and anti-thrombotic therapy in the form of low molecular weight heparin and aspirin may be effective prevention in terms of recurrence of the associated adverse pregnancy outcome. So I took this information from the journal that is cited on the right side of the screen. So other causes of placental insufficiency, which we have to bear in mind as we deal with our patients, placental mosaicism, where you have trisomy 16 within the placental tissue, where the fetus is free of this trisomy 22 as well. Then there is also a condition called chorionic regression, which is partial placental degeneration. And there is a condition where the cord, abnormal cord insertion, where it's called filamentous cord insertion, where the umbilical cord is inserted into fetal membranes rather than into the placental tissue itself, resulting in poor perfusion. So these are some of the conditions to bear in mind, other than just hypertension and diabetes that we commonly think of. And there are some maternal factors, for example, malnutrition, if the patient has iron, folate and protein deficiencies, smoking. And I think there's a patient that we saw and we were querying the possibility that chewing tobacco could be associated. We did not ascertain it, but it's a thought that came to mind. Chewing tobacco as a maternal factor for placental insufficiency. The use of recreational drugs, cocaine, opioids is also associated. And then high altitude exposure for this would not affect Zimbabweans that much, but if you are in Kenya or Ethiopia, where there is high altitude, this is a factor to consider. Fetal factors, for example, trisomy 18, chromosomal abnormalities like trisomy 18 and Turner syndrome, then multiple gestation. And Dr. Ndagurwa has demonstrated to us in the FMU unit that twin pregnancies can have placental disorders. Impaired vascular remodeling, which I have already talked about and alluded to, where there is failure of trophoblastic invasion, and then there is a fibrin deposition, like in the case of our patient where there was a plethora of fibrin deposition in the placental tissue. And we also have inflammation and immune dysfunction. So generally, pregnancy should be have immune modulation, where the immunity tolerates the allograft. However, when there is failure of that tolerance, you have challenges with the placental function. Chorionic regression, we have already mentioned this. So the consequences for the fetus: chronic hypoxia, which leads to fetal growth restriction, and the altered placental transport results in nutritional deficiency. There are increased risks of stillbirth in severe cases. And in our patient, you see that the perinatal mortality, the early neonatal mortality. Some risk factors: increased maternal age, genetic factors, pre-existing conditions, lifestyle factors like smoking, we have mentioned some of these. The clinical presentation, basically, we've decreased the fetal movements in our patient. The baby was just not growing, the tummy was not growing, and the unexplained weight loss or inadequate maternal weight gain is also another factor that we can consider as a clinical presentation. Fetal symptoms, intrauterine growth restriction, oligohydramnios, which is exactly what happened to our patient towards the end. By 33 weeks, 5 days, she had oligohydramnios. Abnormal Dopplers, which were demonstrated in our patient as well, are some of the clinical presentations that we have. Ultrasound, you have, in terms of diagnosis, ultrasound is pivotal there, where we are able to do fetal biometry and Dopplers. And we can also do placental biomarkers, like platelet, placental growth factor and the S-FLEET1 are used in screening for placental dysfunction. I think in the interest of time, I will skip this part. In terms of management, this is individualized. I must emphasize that the management is individualized. We have to consider the gestational age. We have to consider the fetal weight in particular. Those two I saw in a journal that mentioned that those two parameters, the fetal weight and the gestational age, are important in terms of the outcome of the baby. So Dr. Verenga mentioned low dose aspirin, which is 150 milligrams daily, and also the use of low molecular weight heparin, steroids, which were used in our patient to accelerate fetal lung maturation. In fetal surveillance, which was given to our patient, as you saw, those multiple ultrasound scan assessments that were done. And the complications we've already mentioned. For the mother, the complication is a cesarean section. Like in our patient, she now bears a scar for a cesarean section. And there is always, whenever you deliver such a patient, there is a risk of postpartum hemorrhage. Which was not the case in our patient. She did not bleed that much. They called me when they were trying to look for a preservative for the placenta. So in conclusion, my talk is basically to emphasize that placental insufficiency is multifactorial. Even in the absence of hypertension or diabetes, there are other causes of placental insufficiency, and the early detection and management can improve the outcome for both the mother and the child. Thank you. Over to you, Dr. Verenga.
Thank you so much, Doc. Time is running out, but we may have time to take questions. Just to make some few comments and say, the reason why we asked this woman to come every 2 weeks, even though we knew that the Dopplers were that bad, is because we were looking at the viability of this pregnancy. We didn't want to bother the woman much because the weight at that particular point was so low so that you couldn't make a decision to deliver. So this is where we had more of a relaxed follow-up in the initial days until the baby was grown a little bit. Then whenever you are describing the neonatal outcomes in fetal medicine presentations, it's not good enough to tell us the baby died from preterm complications. We want to know them, those preterm complications. This baby have intraventricular hemorrhage. Do the baby have pulmonary other respiratory distress syndrome? Did this baby have some other conditions which caused it to unfortunate demise? Was it a case of hypothermia? Was it a case of electrolyte imbalance? Go and find out the specific cause, because we need women to know what are the likely risks these babies will face when they come out. So we need more detail than to say premature complication, because there are many of them. So please take note of that for future presenters, that you need to give us detail on why is the baby demise, unfortunately. Go ahead, Dr. Nabua.
Yes, I just wanted to ask Dr. Ganyani to highlight the prominent features that were in this case that differentiates the condition from the usual placental disorders secondary to hypertension that we see, in case we come across another patient like this in the future. Well, what was striking about her, which is different from the things that we see in hypertensive patients?
What about you, Dr. Ganyani?
Thank you, Dr. Ndagurwa. What was striking was if you consider, for example, gestational hypertension and preeclampsia syndrome, generally you have problems after 20 weeks of gestation. And this patient had a very early onset fetal growth restriction. So that is a highlight. And also, if we consider the type of management that is being prescribed, whilst yes, there is no evidence of efficacy, but the type of treatment that you give is different. In this case, you would then consider the use of low molecular weight heparin together with the low dose aspirin, as opposed to, for example, if you have a patient with gestational hypertension or risk of gestational hypertension, where you want to just give them aspirin, which has been proven to be efficacious. I think those are some of the things to consider.
So, Dr. Ganyani, maybe a question which you should discuss with your colleague in histopath. He said the giving of aspirin and Clexane, would that not alter the typical histological patterns we should see with these conditions? For example, this guy never saw any clots there, any thrombi. Could that be the effect of us giving Clexane and aspirin? I think it's a question to pose. I know they may not have answers because they have said that they are not looking at enough placentas, so we need to try and feed them more with placentas, those with and those without heparin, Clexane added, so that in the future we could have answers as to the histological picture we saw there. Could we be influenced by the fact that we gave this woman Clexane?
Thank you, Dr. Verenga. I think, yes, the use of low molecular weight heparin will influence the clotting cascade. So definitely to show on the histopathological slide that we submit to them.
Do we have any more questions? Maybe we've just time for one more question. Let me see, there's something on the chat. Let's see if there is a question, but just one question, then we can round it up. Right, so Paranyatra is not charging everyone with no exceptions. I think that was the result, but let's find out from the ground if indeed it needs to summary from the pathologist guys. Ephraim is asked to be excused, Dr. Sona. Thank you so much for coming. Dr. Ndagurwa mentioned that unphospholipid screening in the unnuclear factor before the next pregnancy. That's the correct thing to do. We need to do that for that lady. So please take note of these comments, because this is how we improve the care of these women in their future pregnancy. That if a woman comes, if they do not have blood pressure, but the placenta someone dies early, we should make sure that when they deliver, in between they should have an unphospholipid syndrome screening in the unnuclear factor, so that we wake them up for the subsequent pregnancies. Thank you so much for taking time to attend, and thank you, Dr. Ganyani, for making a big effort to do this presentation. Well done. Thank you, everyone. Next week we may have another presentation. We have another registrar in the radiology rotating with us. So I think next week we'll allow him to present so that we do not pile up the presentation because we still have another registrar in Ops and Ganyani still has to make a presentation. So next week she'll be presenting. In the next week, you'll be presenting at the radiology registrar. Thank you so much, everyone, and enjoy the rest of the weekend and the rest of the Friday. Otherwise, goodbye.
Thank you, Dr. Werenga. Thank you, everyone.